So this is our title today, and it is especially meant to convey. I will tell you beforehand what the main thing I want to convey. It is that even when we are faced with a difficult, fragile, obstructive, unsteady, suicidal, whatever, borderline, psychotic even person, there is always something we can do. And the point is to see what can be done. But the worst is to do nothing, or I mean to give up, to think that we don't know what to do and we'd better stop. That is something that seldom pays good dividends. And I will take the start from this fable by Aesop. And by the way, almost exactly 20 years ago, on this island where I am now, Pantelleria, Lee McCullough and I gave a 3-day immersion course, The Sun and the Wind, that was also inspired to this fable. And I'll go over it quickly. One day, the sun and the wind were just talking. The wind boasted, "I am stronger than you." The sun just smiled. "If you don't believe me, let's have a competition," said the wind. Just then, they saw a man wearing a jacket passing by. The wind said, "Whoever separates the jacket from the man is stronger." The sun agreed and asked the wind to try first. The wind started to blow as hard as he could. The man held his jacket tightly. The wind blew harder and harder, but the stronger the wind blew, the tighter the man held on to his jacket. The wind blew until it was exhausted, but couldn't remove the jacket from the man. Next, it was the sun's turn. At first, the sun shone very gently on the man. The man started feeling a bit warm. As the sun went on shining brighter and brighter, the man felt warmer and warmer. Finally, he took off his jacket. The sun came out as a clear winner in the challenge. Okay, so I think the basic learning we can get from this is that together and strengthen one's inner force is more effective and gives a higher yield than putting pressure to give up a part of oneself, or anyway, what is perceived as being a part of oneself. Today's theme, today's menu, hopefully, is to show how to make it happen. First of all, when we say fragile, and it is a common term, I think most of us use, what do we mean? Generally, we refer to a poor ability to handle anxiety that gets discharged, for instance, via smooth muscle, not striated muscle, or gives rise to physical pain, or affects thought processes. We can see that there is an unstable functioning. Generally, interpersonal connections are disrupted or impoverished. There may be self-harming, sometimes severely self-harming behavior. So we use different labels for this broad category of people. We can say they have a fragile structure, that they are borderline, or they have a psychotic functioning, or simply that they are severely self-harming. And what we mean by that, roughly, is that they are unfortunately unable to make a decent use of their personal being. Now, to maximize the healing process in a low-functioning person, it is of the essence to intercept their resources. Because if we get to intercept their stronger part, it will work as the lever of the healing process. Now, how can we bring about this? How can we connect with the person's resilient, resourceful part? I will consider three major factors for this. The first is lowering mutual resistance. When I say mutual resistance, I mean resistance from the patient as well as resistance from the therapist. I think this is also the first step into a crucial aspect of this subject of my presentation, that if we regard psychotherapy as a human science, we will not use the same type of look, the same way of looking at things that we can use in natural sciences. It is different. When we look at the other person as a phenomenon we observe, ultimately we look at the other person as a thing, or as a specimen giving signals, and we may want to detect signals of resistance. But I think this is wrong, because we are two in the psychotherapy setting, and we interact one with another. So resistance is something mutual. The patient can be resistant, of course, but the therapist too can be resistant. Second aspect, we want to monitor the patient's response to therapist's intervention, to therapist's interpretation, challenge, comment, mirroring, whatever type of intervention. Third, and most important factor, concerns our attitude regarding therapist intervention and patient response. And I'll come back to this at the end of this introduction, after introducing the 9 ingredients. Actually, to maximize the spectrum of therapist intervention and make it possible to find, each of us our own way of going about psychotherapy, I introduced the conceptual framework of the 9 ingredients. These are the main 9 type of, broadly speaking, family of interventions that we can make use of, at least within the framework of experiential dynamic psychotherapy. And it is a totally free range of intervention, whereby me, you, she, he will start from one ingredient, I will start from ingredient A, and you will start from ingredient D, and there is no preordained sequence of ingredients. The reason is that different therapists will feel more inclined to start with one or the other ingredient, and different patients will actually give a better response to one or another of the 9 ingredients. So, one more thing. In IEDP, the name of my specific model of EDT, the favorite way of lowering mutual resistance is to give room and time to explore and take care of the real relationship in a way that is a-technical and a-professional. This doesn't mean we forget about our professional role or that we strip ourselves naked of our techniques. We just put all that on standby position, in order to focus on the sheer human quality of the two people in the room, forming the therapeutic dyad. This is the reason that RE, or working with the real relationship, is one of the 9 ingredients. Now, if we keep RE in mind, we will be able at the same time to try out any of the other ingredients. So here we have a list of the ingredients. Each of them has a short way of calling it. So AD amounts to recognizing and clarifying defenses. AA, or anxiety regulation, is to keep anxiety within a favorable range, favorable to emotional experiencing. SE stands for superego and regards the work on the self-sabotaging part versus the person's will, the deep essence of our being. RE, we know, is working with the real relationship and focusing on personal aspects. MI, or mirroring, frequent mirroring, amounts to catalyzing interaction between patient and therapist, and also enables to gather data. SO, self and other, amounts to focusing on interpersonal patterns of relationship. HP, history and perspective, will help us to unveil the subjective truth. Emotional maiutics, the art of the midwife applied to emotion, helps the person to deliver emotional truth and ultimately to experience, to feel the feelings. TCP, the more classical, the most classical type of psychodynamic intervention, amounts to making links between the therapist's current life and past life. And it is like unveiling the historical truth. Now, here we have Malan's triangles, and I put them here in the lower part of the slide. I'm sure Jonathan introduced you to the two triangles to show that they encompass all the theoretical aspects, and in a way the 9 ingredients are meant to take care of the operational side of how to make it happen, of the more technical aspect. But the two triangles are of the essence, and are a wonderful way, a wonderful scheme encompassing. We have defense, anxiety, and hidden feeling or impulse, the transference or therapist. C stands for current significant people. P stands for past significant people or parents or caregivers. I actually added a few arrows here to also make out the attachment between self and other. So the way I imagine, myself when I give therapy is more or less this one. I put me and the other person at the center of this polygon, and we are the real relationship. And at the angles of this polygon, there are all the other ingredients, as we saw in the former slide. So we can circulate around the ingredients as we wish. Now, here comes into place the third factor, the one I mentioned before, and it is about the very essence of our discipline, psychotherapy. For cultural reasons, we tend to think of the patient as someone in need of our intervention. So the severer their condition, the more they are needy. They need us. And the more we need to give them help using our technical tools. So here, the stress, the emphasis is on need. Need is something obliging, something we cannot do without. Now, we can decide to stop regarding the fragile person as being a kind of hyper-needy being. We can try to make a shift, and instead of focusing on what they or we need, we can try to focus on what they want. If, for example, we make use of the 9-ingredient concept, we can wonder which ingredient may this person want in this moment. So instead of regarding them as undefended, fragile, helpless in a way, we can try to help them intercept what they want in that moment. So another thing that I thought about is that fragile people rarely are fragile, idiosyncratically. Most often, they become fragile because they already abuse themselves. So, in a way, if we regard them as being will-less, we abuse them further. If we instead strive to connect to their will, we value what they want and indirectly what they are able to do. In this way, I think, by changing attitude in this direction, you can get, to put it this way, two birds with a stone, because the dyad, the therapist and patient dyad, will benefit at the same time from the technical intervention itself, from the technical intervention we use, and from directly connecting to the patient's will. And this is empowering and therefore most important in a fragile person. If they feel that their will, what they deeply want, is being seen and valued, treasured by the therapist, this has a direct, powerful impact on the patient's motivation to engage in the process. In this way, we may convey that healing is possible and spare them the trauma of putting a sometimes counterproductive pressure they wouldn't be able to bear and to make good use of. If we try to connect to what they deeply want, and of course translate it into some type of intervention, this creates a sound motivational basis, the essence of which lies in the patient's conscious and unconscious perception of the therapist's will to be connected with them, which is very value-adding. Now, what applies to resistance seen in this way, that is that it is mutual, it is resistance from the patient as well as from the therapist, it can be, applies as well to therapeutic alliance. Since psychotherapy is a human science and not a natural science, it is crucial to look at it in terms of the relationship. So also therapeutic alliance, we should not regard it as a kind of mysterious, only unconscious phenomenon that we therapists, guru therapists, see the signals of it. Rather, I think we should tune in to the interpersonal atmosphere and try to sense the therapeutic alliance. That is not just unconscious, it is also conscious. Now, we'll go to see a few ways to enable these fragile, unsteady patients to make use of their resources. And we'll see that in 4 different cases. The first is an acutely suicidal person. The second, a case of psychosis, no, actually the second will be a borderline, the third a psychosis, and the fourth chronically depressed. I will show you this last slide that is about John Bowlby's seminar that he gave in Milan many years ago. We invited him and it was wonderful. And here there is the transcript of the seminar and also a chapter on attachment theory and experiential-dynamic psychotherapy. Okay, and this is in Italian, like in Nuovo Cinema Paradiso.